Sorry, I've just realised I've been speaking whilst on mute that whole time, so sorry about that. Good morning, everyone. Before we start, just want to run through some digital housekeeping. So could you please keep yourselves on mute? I realised I was doing it myself. We will be recording the session, so please feel free to turn your cameras off if you prefer not to be recorded. We will have time for Q&As later on, so please feel free to post any questions in the chat. And having said all that now, if we haven't already started recording, we'll press record. Okay. I'm really excited to be joined by David Shires today, who will tell us more about the Leicester tool and why it's such an important resource in helping to tackle the health inequality of a 15-year mortality gap faced by people experiencing severe mental illness. In this webinar, we will explore how systems can improve the physical health of their local population with severe mental illness by using the updated tool. And we've had a last-minute change to the agenda today. Unfortunately, Dr. M. Tiffin was unable to join us and sends her apologies, but Professor Carolyn Chu Graham has kindly offered to step in, so thank you very much. We really appreciate the last minute stepping in. We'll also be joined by Catherine Patterson from the British Dietetic Association, who will talk a little about how dietitians are best placed to implement the tool early. So I'm going to hand over to Hannah Moore, who is our the Vice Chair of our Expert Experience Group. Sorry, would people just mind putting themselves on mute, please? Thank you. And Hannah will be talking more about her lived experience. So Hannah, I'll hand over to you if you want to make a start.
Hello everyone, I'm Hannah Moore. I'm the
I think you've gone on mute, Hannah.
Hello, sorry. Yep, I was on mute. Sorry, I did a Shazana. I'm Hannah Moore. I'm the Equally Well Vice Chair for the Expert by Experience Group for Equally Well. So we are a co-produced group of Expert by Experiences, people who have lived experience of severe mental illness and professionals of all different capacities, and we work together to basically look at the physical health within mental health, because everyone knows it's not always as good as it should be. And so we a little bit about myself. I was put on medication around the age of 10 or 11. Before that, I was a dancer and a gymnast, and when I was put on the medication, I think it was risperidone at the time, I managed to put on about 4 stone in 4 months and then carried on putting on weight. By the time I was 14, I was admitted to child and adolescent psychiatric hospital, where I stayed for most of my teenage years. And then I've got 20 years experience of inpatient services, going in and out, and different types of services, secure and PQ and acute, and all of them, my physical health has never really been looked into, and that's part of the reason why I joined Equally Well. And I'm here just as an expert by experience, because obviously everything is co-produced. We chair together, like we have Shazana and we have me. So yeah, I hope that gives you a bit. And I'm just going to hand you over to David and Carolyn now for their presentation. Thank you.
Thanks, Hannah. So now, if I can get the slides right, I hope you're seeing some slides. Is that working?
Can we put it on slideshow?
Yeah, we can see them.
That should be on slideshow. Yes, how's that? Is that working for you all?
Yeah, that's good.
Right, hi. So really just picking up what Hannah said, my name's David Shires, and I really can resonate with some of what Hannah's just said. So we'll just introduce ourselves first, and then we're going to talk a little bit more about the Leicester update. So my background, I live in Leek in North Staffordshire. I was a former GP. I got involved in mental health reform through the lived experience really of my daughter developing a major psychosis when she was 16. So Mary's now in her mid-40s. She was given a diagnosis of schizophrenia when she was 16. I've then got involved in early intervention in psychosis reform as a joint lead through the National Service Framework era. The last 12 years, I've stayed sort of retired, but actually with a number of honorary appointments. So with Keele University, with Greater Manchester Mental Health Trust. And I've been involved in some nice guidelines. So I've really moved the last 10 to 12 years to advocate for one of the big gaps I felt in early intervention in psychosis, the issue of people's physical health. So that's me. Carolyn, do you want to? I also, can I just bring the preface this, because Carolyn, up to 24 hours ago, didn't know she was actually going to be helping to do this presentation today. And I think, Carolyn, you deserve a medal for this. And perhaps that would be a little something you could talk about as well when you introduce yourself.
Thanks, David. And yeah, welcome everybody to this webinar. So I'm a GP, I'm Carolyn Graham. I'm a GP in Manchester, still a principal after many years. And I'm also a researcher at Keele University. Predominantly my research is around mental health, and both severe and enduring mental health problems and also common mental health problems. And I tend to use qualitative methods. I've worked with David for quite a number of years on trying to improve the lot of people and their carers with severe mental illness.
Great. Okay, so what we're planning to do today is I could try and give some perspective on why physical health matters for people with severe mental illness, families like mine. The sort of issue about primary care or specialist care, whose job is it to give support? Then give you a little bit of background about what the Leicester tool is and really how it came into being. What's new in the latest update? We've just released an update about 4 months ago now. And then Carolyn in particular is going to talk a little bit about primary care and how primary care can use the Leicester tool. So that's the sort of aim of what we're planning to do. Okay, so just to give you some further sort of insight into why I feel this is so important for families like mine. So this would be this is late 90s, and Mary is eldest, three children, very fit, very active, very keen on pets and getting outdoors. That was her great love of life. None of us knew what was coming, but by the time she was sort of mid-teens, she began to get struggled at school, moody, felt depressed, and eventually with a suicide attempt at home, psychiatrist came to see Mary, and he was diagnosed quite confidently that he thought Mary was experiencing schizophrenia. 12 months of a CAM service where the psychiatrist did his best, but he frankly admitted that if we could hang on to the adult service, they're more into psychosis. So that was 12 months where Mary was struggled really at home, along with the rest of the family. 6 months of a very chaotic acute adult ward, and we discovered then that although the service might have been more experienced at dealing with psychosis, it certainly didn't deal with young people. And then finally, Mary moved into the asylum, and onto the so-called rehabilitation ward of the local asylum. And that was within my practice area. So Mary had a couple of years in this very grim Victorian environment. And essentially there, she was very heavily sedated. She spent most of her time sitting down. There was a culture of smoking. I still have memories of walking along the old corridors and seeing groups of elderly men smoking cigarettes. Meantime, Mary was taking a lot of antipsychotic medicines in big doses because she was the psychosis was unremitting for a couple of years. And in that environment and with those medicines, Mary was then given extra helpings of puddings by the staff because they felt sorry for her. There was nothing; she had nothing else to do. So Mary's weight went up by 50% from her. She went up from 9 stone to 13.5 stone in about 2 years. So I really wanted to highlight that this wasn't Mary's lifestyle choice. This was absolutely to do with the environment, and she had very little choice in anything that was taking place at that time. So essentially, and I'd label this slide as she was flattened, and also forgotten. So her life just completely existed inside this mental health ward. So just to highlight that at that time, me as a GP, I was giving advice to people about their physical health, generally to a population in their middle-aged, in the 40s and above, about how they could improve lower their risks of having heart disease or diabetes. So that was my job, and yet at the same time, I was witnessing Mary exposed to exactly the same issues that I was trying to give advice on, and Mary was 20 years younger. So it certainly struck me very strongly that what was happening to Mary in that age, because of her severe mental illness, were the same issues that I was trying to give advice to for an older population. And so the trajectory of weight gain that Mary experienced was exactly this. This slide summarizes a review of evidence, the effect of antipsychotic medicines on weight gain. And what's really striking is the speed at which this weight goes up, also the scale of it. So the average weight gain within 24 months was 12 kilograms in this study. So that's people experiencing psychosis for the first time. So that was the real issue, a really rapid take-up in weight. And of course, the issue for Mary wasn't the threat of dying or heart disease or diabetes. It was that she didn't look like her friends. She couldn't wear the clothes. She couldn't move quickly. So all of those things were very personal to Mary. And the problem with so what was actually happening then? Mary's risks of developing issues that would later determine her risk of heart disease and diabetes was very clear that metabolic syndrome was, from having no increased risk before she became unwell, she was now faced by now her current age of having something like 4 times the risk of having metabolic syndrome compared to her brothers. And this trajectory follows the rise in weight. And that will explain, so that this is a very large systematic review looking at mortality, and the really striking thing here is the risk of heart disease and stroke. This is the single biggest cause of reduced mortality for this population. So by the age of 50, 10% of this population have actually experienced one comorbid cardiovascular disorder, stroke or heart trouble. It's also twice as likely to be lethal for that population. So that's the same age as Mary is now. And then looking at since the 1990s, so Mary became unwell in the mid-90s, and this graph shows the mortality gap actually widening for this population. So whereas the general population we've seen gradual improvement in life expectation, but for people with a diagnosis of schizophrenia, we're actually seeing the life expectancy slightly fall. So the gap's widening, and it's still widening, and that's really a lot of the motivation for why we feel the Leicester resource is so important. Okay, Carolyn, I'll let you pick up slides here.
Okay, so with my GP hat on, I'm going to ask to think about whose job it is to manage, monitor the physical health of people with SMI. We're going to come to the Leicester resource later to just tell you what's new, and also think about not just screening but intervening. I think that there's a big role for general practice in doing this work, partly because 50% of people with severe mental illness are based in general practice. They don't have any contact with community mental health teams. So we're the ones in primary care providing support and monitoring people's physical health. So David and I wrote an article for the British Journal of General Practice, an editorial, which again, I mean, we've done this before, haven't we, David? But again says, look, this is our job. This is what we should be doing in general practice. And we've got the Leicester resource, use it. So as this quote that David's put in, it's everybody's business. But also it's important that there's communication between primary and specialist care, and I'll come to that at the very end. But what we see is that people either get, if they're lucky enough to have some CMHT, some community mental health support, they might get a physical health check there, and they might get a physical health check in general practice. but other people fall through the gaps and don't get one anywhere. So there's duplication, fragmentation, systems don't talk to each other. And the key thing is that I think some of us are very good at doing the check, but what we're less good at is following people up and actually intervening. Next slide, please. We have in general practice something called the Quality and Outcomes Framework, the QOF, which I'm sure some of you will have heard of. And this dictates certain processes of care that need to be done in general practice. And if those boxes are ticked, then there's a payment made to general practice. So there are targets around the physical health monitoring of people with severe mental illness. We know that if something is included in QOF, in the Quality and Outcomes Framework, then it's done. So when QOF was first introduced, GPs were very good at doing the process of care, ticking the boxes. What we also know that if a target isn't mandated, particularly if it falls out, because QOF is revised every year, and if a target falls out, then it's no longer done. And we've seen this with some of the targets around physical health of people with SMI. When QOF first came into being with this target, there were about 22 indicators that had to be done. There's now about 12. And the evidence is that those that have dropped out just don't get done. So it really should be incentivised. Next slide, please. So just think about what NICE recommends, because again, this should dictate what happens in general practice, but also in specialist care. So NICE Clinical Guideline 178 says that primary care should have a register of people with a psychosis, with schizophrenia, and they can utilise those registers to monitor the physical health of people with severe mental illness. The QOF, the Quality and Outcomes Framework, also asks us to keep a register. That's incentivised, so that's on the whole done. NICE says that people with a psychosis, schizophrenia, but particularly those taking antipsychotics, should be offered healthy eating and physical activity programme. NICE says the mental health care provider. And I think this is where people fall through the gaps, because in primary care, people will be offered a health check, a physical health check. They should have their BMI measured. They may be given advice by often a healthcare assistant who's doing the check, but there isn't anywhere specific that a person with SMI can be directed to, and they may not want to go to Weight Watchers or the other programmes that are available. All the programmes are for people with diabetes, they're not for people with SMI, and people are actively excluded. Similarly, in specialist care, they may not have access to healthy eating or physical activity programmes. NICE says that if people have got rapid or excessive weight gain, abnormal lipid levels, abnormal blood sugar, then we should be offering interventions. And this is really what the Leicester resource says. It's don't just screen, don't just do the blood test, don't just tick the box. You need to do something when somebody's lipids come back as abnormal, when their HbA1c or blood sugar is high, when people are putting on weight, do something about it. NICE also talks about the need to help people stop smoking. We know that 45% of people with SMI will smoke compared to 15% of the general population. And we also know that smoking impacts on the drugs that people take. And if people do reduce or stop smoking, then that can impact on the metabolism of some of their drugs. That's quite specialist, and GPs may not feel quite skilled enough to monitor drugs, but well, particularly clozapine, we have no role in that. So the question is, where should this happen? Next slide, please. NICE also looks at bipolar disorder and again advises that people with bipolar disorder have a physical health check in primary care. And NICE stipulates what should be done. And again, some of these are in the Quality and Outcomes Framework. So if somebody has got bipolar disorder, it's properly coded and they're listed on the Severe Mental Illness Register, they should be invited in for this check. David, I think over to you. You're on mute.
David, I think you're still on mute.
How's that? Can you hear me now?
Thank you.
Slides have gone.
Now the slides have gone. I've got to multitask. This is beyond my ability. And how's that?
Fab.
You can hear me and you can see the slides. That's a good start. Okay. This presentation really wouldn't be complete with talking a little bit about the late Helen Lester, who's a close colleague of Carolyn and myself. We've just put a link here to a really essential reading and viewing. I'd really urge you to have a look. This is the James Mackenzie lecture from 2012, which was about 6 months before Helen very tragically died. So Helen and I, we ran a workshop in the International Early Psychosis Association in 2010. The first time they'd actually run a symposium on physical health. And at the end of it, Helen and I said, well, if anyone's interested in this topic, we're going to be having a cup of tea in that corner over there. And 6 people came over, one of whom was an Australian psychiatrist from Sydney called Jackie Curtis. And she was waving a plasticized algorithm that her team had developed over a weekend for training. As a gift, and Helen and I took this home and back in the UK, and immediately Paul Lelliott, who was then the director of the National Audit for Schizophrenia, and I was doing a very part-time job there. Paul said, "Look, David, your job is to nick this from Australia." Helen had the ability to actually. We drew in the colleges of psychiatry and general practice to look at this resource very carefully. We spent great care. It took us 18 months to review the resource, and essentially we proved what the Aussies did in a weekend. It took us 18 months to prove it was okay. So it was pretty close actually to the original Australian resource that we nicked. It was then went through a process of development with NHS England being involved, Public Health England. Tragically, Helen was actually dying at the time. We had a difficult conversation. Helen sort of, yes, okay, well, so we called it the Leicester Resource, really to reflect Helen's standing here, because as a senior GP academic, Helen had overseen the whole of the QOF, not just the part on mental health, but the whole of the QOF when it began in 2004. She's an absolute tower of strength and highly respected for her work. So the Leicester tool became then part of the makeup of how the national audits were being performed. NHS England backed it to be a supportive tool for the Sequin, which went on, I think, for several years. So the Leicester itself became well established. But I really wanted to just pay tribute to Helen for the, because it couldn't have taken place without Helen. Now then, let me just check where I've got to. Yeah. So about. I think about 10 months ago, NHS England were aware that NICE were updating their vascular guidance, the CG 181, the vascular guidance, in which they were going to alter the recommendation for cardiovascular risk measurement using QRISK 3 instead of QRISK 2. So that was a prompt for looking at the Leicester, because it was going to go out of sync, and we were very keen indeed that we stayed closely linked to how NICE were responding to vascular risk. So that prompted a review, and we updated resource with Carolyn and several others involved, and this was released about 4 months ago as an updated Leicester. It's essentially the same process, but we've just made this accommodation for the update of the NICE guideline on vascular disease. So essentially what we're trying to achieve with the Leicester is to create a sort of shared framework, whether you're a GP, a nurse, working in primary care, specialist care, that actually these are the essential components of of how we should be concerned about people taking antipsychotic medicines with a diagnosis of severe mental illness. So that's essentially the framework for it. We're hoping that it's a basis for which we can create good communication. That's one of the essences here, is so that people are clear about what's required, as I say, irrespective of your background. Just to talk a little bit about the amendments in the most recent 2023 update. very conscious of this, don't just screen, intervene, and then the importance of emphasising this. So we've tried to refine the language a little. So it's a little bit more about doing and not just considering. We've specifically looked at ethnicity cutoffs and how they relate to BMI and waist circumference. Particularly importantly, we're trying to emphasise this issue of early weight gain. The problem is that early rapid weight gain predicts those people who are most likely to gain weight over the longer term. So we've really tried to emphasise that. We've also clarified that cardiovascular risk tools actually underestimate risk. They're so dominated by age that for, say, a 20-year-old like Mary would have been initially, that they're relatively unhelpful. They certainly severely underestimate risk. So this is a population at very high risk, that age group. So we need to be clear that cardiovascular risks underestimate risk.
Can I just say something, David, on the previous slide?
Yeah.
So I think these weekly weight checks are really vital, and they're often not done. And it's just to say, people who are initiated on an antipsychotic, that happens in specialist care. GPs don't initiate antipsychotics. We don't give diagnosis of SMI. And we often don't see people when they've started on their antipsychotics. So it's really important that in specialist care, there's provision for physical health check, for weight monitoring right from the start, rather than, in a year's time, the person will be eligible for a physical health check, which is unfortunately what happens.
Yeah, brilliant, Carolyn, absolutely. So, and then we've emphasised again that the health behaviour advice extends to alcohol use and physical activity, as well as diet and smoking, which was already present in the previous Leicester. And then specifically for those who are at high risk of developing diabetes, then if dietary modification is ineffective, then there's now a modified release version of metformin, which is licensed for prevention of diabetes. Okay, Carolyn.
Yeah, so back to where we think primary care has a role to play in monitoring people with severe mental health problems, but also managing. So they're not just screening, intervening. So we've got the Leicester tool, we should be using it. How can we do that? Key is also smoking cessation and also supporting carers. So as we've tried to say, it's everybody's business. So just a reminder, David's gone through the Leicester tool. It's quite easy. You can print it out, laminate it, put it on the wall. And this is what we've done in our practice, so that any clinician who sees a person who's got severe mental illness, if there's a reminder that this person needs a physical health check, they can say, well, shall we do this now, or can we book you in with a healthcare assistant? The healthcare assistant's got this on her wall, so she knows why she's doing all the blood tests. But then it's the intervening. Have you got a system in your practice where if somebody's had the health check, they've had the boxes ticked, they've had the bloods done, they've had a BMI checked, they've had the blood pressure checked, what happens next? Does this person then have a review with a GP or another practitioner, a pharmacist in the practice, to say, okay, so you're taking quetiapine, I noticed that your weight's gone up. What can we do about that? Or I noticed that you're smoking. Can we help you with the smoking? Or I noticed that your HbA1c indicates that perhaps you're at risk of diabetes. What can we do about that? So it's getting that next step, that intervening step, which is really key. So thinking about smoking cessation, I'm sure a lot of you will be aware that with and I'm not going to be political, but with the austerity measures have really got rid of a lot of the smoking cessation services, certainly where I work. But for people with severe mental illness, they need support, and the evidence is that they need tailored support. So possibly the brief interventions that practice nurses are able to give may not be sufficient. The Scimitar trial, led by Simon Gilbody in York, said it has to be a flexible, in-person, ongoing, tailored intervention for people with SMI to really support them, not just a quick chat and a prescription of some replacement. And, as I say, we don't have the smoking cessation services that we used to have. The other key role for primary care is that we should be supporting carers. We know that being a family carer for anybody with any long-term condition can be stressful. It can be particularly stressful, as David's pointed out, for people who are caring for a person with SMI. And where in a general practice, if we know that we've got a person who's got a severe mental illness and we've also got their family registered, we ought to be registering them as carers, we ought to be adding that code, but perhaps we ought to be inviting them in or sending information about carers groups, because I think the needs of carers are lost in primary care, but possibly also in secondary care. So again, David and I have been trying to highlight this. The key thing that it's about, it's everybody's business, so everybody in the health and social care sector. For me as a GP, it's really important that we're able to collaborate with specialist care, that we have a bridge across the primary secondary interface. And that's a really nice example of a bridge. But what often we find, and this is a political statement, is that it's a brick wall. It's really difficult to get people seen in specialist care once they've been discharged, unless they have a real crisis, and then the advice is often send them to the crisis team. That there perhaps in the good old days there used to be better collaboration between primary and specialist care. We used to have liaison meetings, and that's where we can talk not just about people's mental health, but we can talk about their physical health, and we can learn from each other. David, you're on mute. Oh.
Does it automatically? I'm beginning to learn how to use this. Right, bear with me. Normal service will be resumed. Yeah, so I really just wanted to say that it's also our business. So from how I've described Mary's original development of illnesses in the 1990s, it's now 30 years on. Mary lives in a fantastic supported home close to where her mum and dad live, so we're a close family. This is Mary in her 40s. She takes great pride in her appearance. This is a really important thing for her. So the last 30 years has been a struggle. She was effectively, I think, written off in the late 90s. We had to work very hard to get beyond those first few years. It's been an extremely hard struggle. It was greatly helped by Mary starting clozapine. Clozapine certainly treated her mental illness very effectively, but it left her with a whole range of other issues. So now 30 years on, Mary's mental illness has very little part to play in her difficulties. What is really difficult is managing the 4 conditions that she now has. There's an awful lot of time spent navigating different parts of the health system. She takes 11 different pills and her brothers take none. So those aspects, that's what Mary's business is, if you like, now. That it's really consumed by managing her physical health difficulties. She's very dependent on others for help. But as I say, a quality of life, she's in a very good state at the moment, and her quality of life is excellent. In terms of our business, it's also, for me personally, some unfinished business. So the physical health of people like my daughter is still, for me, unfinished business. That's why I still feel very strongly about the importance of things like the Leicester resource, and why it's still relevant today, thinking back to those early experiences. So I think that's probably where I should start. I suppose the other final point I'd make is that this is about having a life worth living as well. So for Mary to be to doing well at the moment, the treatment is important, the clozapine is important, but so is all the surrounds that give her support. So to take your physical health seriously, you do have to have a life worth living. So I hope that's given you some insights into how the Leicester came into being, how you've got 2 GPs still involved in supporting it, and we'll thank you for that. And now I'm going to try to introduce Catherine, who's going to give a dietitian's perspective. Bear with me. I think I've done, yeah. And just to point out, Mary's never ever seen a dietitian in 30 years. So it's really very important to have Catherine's perspective on this. Over to you, Catherine. Catherine, are you there?
I'm a specialist dietitian in the east of England. I work in heart health, diabetes, weight management, and also mental health through various NHS contracts, and have 20 years experience as a dietitian. I'm also part of the clinical group for Equally Well UK, and I had the privilege of reviewing the tool for the British Dietetic Association. And our logo will be added very soon to the Leicester tool update. So dietitians are involved in the intervene part generally. Other people generally do the screening, although we do have first contact dietitians now working in primary care. And dietitians can be best placed to implement the tool early if they're working perhaps in mental health, by helping with prevention of weight gain. Of course, prevention is better than cure, and we want to try and prevent or minimise weight gain for people, particularly if they're starting antipsychotic medication.
Catherine, so I'm sorry to disturb you there, but we can't actually see you.
Thank you.
I don't know if that's your end or our end, or if anybody's still got the slideshow on.
I've got a frozen picture of Catherine.
Do I need to go into the meeting rather than the original link that we went in together?
No, we're still fine on the original link.
Catherine, it might be worth just turning your camera off and on again, because I think it might be that your camera is frozen on your end. I don't know if you want to try that.
There we go.
All right.
Thank you,
We can see you
Catherine.
now.
Okay,
Sorry
thank
about
you.
that.
Yeah. So our role could include as part of a group sessions perhaps, or individual nutrition counselling for people perhaps in early intervention services. And we've got some evidence to support the benefit of nutrition interventions using dietitians in those settings. And it's important often in these settings to include meeting the needs of people, such as accounting for housing, finance situations, access to recreation and physical activity, and enhancing cooking and shopping skills where that's appropriate for individuals. NICE, as Carolyn mentioned, recommends that mental health providers mental health trusts provide health eating and physical activity programs, particularly for those starting antipsychotic meds. That doesn't always exist, and so this is where I think dietitians could be part of that, in particular, perhaps along with physical activity personnel. And so what often people are left with is actually the Public Health Commission's weight management services, which may be slimming clubs, for example, Slimming World Weight Watchers on referral, although there's some others, depending on where you live, there's access to some nutrition education courses, but not always targeted to meet the needs of these groups. The other thing I wanted to mention, or that I am concerned about, is access to weight management services that are commissioned either by public health or by the NHS. The NHS Tier 3 weight management programmes often provide a year-long programme for people, and or at least in my area, they're commissioned to meet needs of people with severe mental illness. And I'm not saying it's every need in terms of prevention of antipsychotic weight gain, but we're seeing in the country, or I'm seeing that it feels like a decrease in the number of these services, and people who with severe mental illness, I'm concerned that it might increase the inequality, because the access to these services appears to be different across the country. Some areas don't have either public health or NHS commissioned services, as far as I'm aware. And for example, if it's only a digital NHS service that's being provided for people, that might not meet the needs of everybody in our population. And perhaps our colleagues at NHS England may be able to comment on that today. So I'm concerned about, because I do work in a tier 3 weight management service at the moment, but I can see changes happening with that. I do think dietitians have an important role to play in prevention of weight gain, but also management of conditions that people are affected by because of weight gain, including diabetes, cardiovascular disease, for example, and dietitians have the knowledge and skills to provide those services. That's all from me today.
So thank you, Catherine, and David and Carolyn. That was really interesting, and I completely resonate with Mary's story because I was an active child. Like I said, I did gymnastics, and it was the weight gain that stopped me from doing anything, and the sitting in hospital doing nothing. And I think this Leicester Toolkit is very important. And yeah, I just think a lot more needs to be done about weight gain, physical health for people with mental illness. We're now going to have a question and answer session. So I'm going to ask some questions to David, Catherine and Carolyn, and Shazana's going to pick up some questions in the chat. So if you have any questions for the panel, or for me, or for Shazana, or that's fine, please put them in the chat. That's great. So shall I start with the first question, or have we got one in the chat ready, or shall I just start with the first question?
If you could start with the first question, yeah. That'd be great.
Okay.
Thanks, Hannah.
So to the panel, how does NHS England encourage systems to prioritise this work?
We need Layla on this one, I think.
I can. Hi, I'm Layla. I can jump in on this, even though I'm not on the panel. So I think I might be the representative of NHS England here for my ills. So a big part of this, the promotion that NHS England does, is obviously the physical health checks are part of the long-term plan ambition. So there's an ambition for, by the end of this year, 390,000 people who are living with severe mental illness to be receiving an annual physical health check. And that's about 3/4 of people who are on primary care registers. So to drive that work, there's lots of work focused on the delivery of the actual physical health checks themselves. But as we've just been talking about today, the physical health check is the first step and is, obviously not the be-all and the end-all. And the Leicester tool is really striving to bring that focus on intervening based on what comes out of those health checks. So Carolyn and David and many others, some of whom are here today, have also been involved in updating the national guidance, which I'm hoping is getting signed off by the bigwigs this week to be published, which has a really strong focus on what those follow-up interventions are. I guess the other bit to flag is when we're talking about areas, so we talked about smoking interventions earlier. There is work done nationally that's piloting the scimitar model in the community, and so things to try and push that to kind of national rollout and so forth and so on is really what we're doing to try and focus in this area. But often it's people with the passion and the expertise who've kept it on the agenda for so long, and so that's not necessarily NHS England who can take that, but there's lots of work ongoing.
Thank you, Layla. I completely agree. I'm actually about 64 days smoke free now, so that's
Great.
really good. So and vape free. Haven't vaped since the 4th of August. So smoke and vape free. Lost 8.5 stone now. So yeah, doing well. So have we got a question in the chat? Or
yeah, just something that we've been chatting about earlier on. So David, will there be an updated adolescent version of the tool?
Yeah, I mean, the process has been great. We've had some critical comments about the current tool, that because it doesn't allow for growth in adolescence, it's really essentially made on adult ranges, adult range of your, your blood pressure or your weight. So actually, we're working with NHS England and other colleagues to try to develop an extra page that will look a little bit like the traffic. It will look very like the traffic light version we currently have, but it will say for adolescents, because it will acknowledge the fact that this is a growing population, and using centile charts would make a lot more sense when you're trying to judge whether someone's got a blood pressure that's normal or abnormal. Same for BMI and weight. So I think that's going to be very helpful. I think it'll take us probably 3 or 4 months to sort of scope it out and get practically done. But I'm hoping that by early next year, we'll actually make the current list one page extra, which will have a page for people with adolescent needs to match their adolescence. Yeah. So watch this space, twinkle in the eye.
Thank you, David. I will ask a second question, if that's okay. So to the panel, how can we provide like a holistic approach to cover the physical and mental health elements of care for patients? And do you have a good example from other trusts to share?
Shall I? I can sort of give a response to that, I think, Hannah. I've always felt that this is about body and mind. That so dealing with a severe mental illness, whilst dealing with a psychotic distress is incredibly important. Being there, seeing the impact of that, actually to ignore someone's physical health at that time is really has long-term consequences. So 30 years on, the consequences for Mary are all about managing physical health. The opportunities to try and avoid or delay that problem was right at the beginning. So I still feel very strongly that this early intervention reform, great as it's been, there's an unfinished business here about trying to tackle people's physical health early on. In terms of good examples, I'm afraid we do have to go back to my Australian friends in Eastern Sydney, who've developed a Keeping the Body in Mind program, so that anyone coming into their psychosis gets to see Scott, the nutritionist, and Simon, the exercise physiologist. They're just part of the team. They've run cohort studies comparing what their service achieved compared to another service in New South Wales, some distance away, and what they saw in the first 3 months. So just bear in mind that incredible trajectory of weight gain that we showed earlier. They've effectively stopped weight gaining in that first 3 months. In fact, what they noticed was that there was a very small increase in weight, but it appeared to be muscle rather than fat, that their actual BMI structure was improved. So that's proof of concept. They're a charismatic service. They've got great leadership. I'm not for one moment thinking you can transplant that service in lots of other services, but they've proved the concept that if you take this really seriously right from the beginning, you can alter the trajectory of this. So I think that's something I would add to this, taking it seriously very, very early on, and that's one of the objectives of the Leicester.
And can I just
Karen? Oh yeah, I was just going to say Karen's got her hand up. So yeah,
and it's about primary and specialist care working together, and some work that David and I are involved in at the moment around early intervention services. In the qualitative study, we've discovered that GPs perhaps don't have anything to do with patients if they're in an early intervention service. They disappear from primary care. And then 3 years later, they land back in primary care with no established relationship with a GP, possibly without any support from specialist care. And so it's back to my bridges and brick walls. Actually, primary care liaising with specialist care, liaising with social care, so that people are protected and supported and managed as a whole, rather than, oh, well, the CMHT will manage their mental health, and oh, the GPs can do the physical health. Yeah, so back to, can we have liaison meetings between primary and specialist care, please? That would be great.
We have someone, Leonardo, in the chat who has her hand up or his hand up.
Yeah,
Sorry.
hi, yeah, it's Leandra, yeah.
Sorry.
there. Yeah, it's okay. I just kind of wanted to share what's happening in my locality, and I'd be interested to hear from anybody else if something similar is happening. So I'm a qualified mental health nurse with many years experience, and I've just joined a new team. It's been established for about a year now as a senior physical health clinician working in secondary care mental health services. And our local, our division, BSW, in the southwest area has commissioned and paid for us as a team to be implemented within the wider community mental health teams, EI and complex intervention teams for older adults, to really kind of raise awareness and embed the absolute need for parity of esteem with physical health alongside mental health. So we look at those patients on the SMI register who haven't had their annual physical health check the information on the ICR viewer if they've had it in primary care, and if not, pick up those gaps to make sure that people are being seen, and then feed that back to GPs. So I mean, I'm new to the role, so I'm not sure if this is happening across the board, if this is happening in other patches, but I just thought I'd just bring it really because it's obviously really relevant.
Fantastic.
Thank you. Shazana, shall I go for another question, or would you like to pick one from the chat?
I've actually got one for you, Hannah.
Oh, okay.
What do you think would have helped you in the early days to support your physical health?
I think instead of being put in on a lot of medication to begin with, and an inpatient service where all people did was smoke and eat, and I think someone recognizing that I was putting on weight, someone actually saying, "Honey, you've put on a stone in a month. We're a bit worried about that." I can remember after I'd put on probably about 6 stone, someone went to my dad, who I was still in contact with at the time. One of the nurses, I think she was one of the education people in my child unit, and said, "I think Hannah needs some new clothes." And I was just like, I did. I was still wearing the same clothes of the dancer that was with my belly hanging over and everything like that. And I think what would have helped me is if someone had initiated that with either my dad or my carer then when I was in foster care and stuff like that, or even with me, because I was too doped up to even really think of anything. And it was just, take this, eat this, here's another cake. And that was it, really. There wasn't, especially as a youngster, and I was put in adult services when I was a youngster as well, because when I was 15, and they had the old time smoking rooms, and so I went from smoking, say 15 a day to 40 a day in the adult service. And then when I transitioned into adult services, it was even worse, and I continued to put on weight, and I got to over 25 stone. And I'm just lucky. I've been doing Weight Watchers actually, and managed to lose a lot of it. I still got a long way to go, but yeah, someone actually pointing it out to me in the first place, like having weigh days like they do now in secure hospitals, where they have a weekly weigh-in. And I actually did a review of a hospital last week who does weekly weigh-ins, and whoever loses the most in the week gets a £10 voucher. So instead of rewarding them with food, reward them with something that is good. So like I've started to reward myself with, when I get down to my lowest weight that I have been lower than this before. And when I get down to my lowest weight, instead of rewarding myself with food, I'm going to go to Adventure Island, because I know I'll be going to be able to fit in the seats of the rides then. So yeah, I hope that's answered the question. Probably babbled on a bit as well, sorry.
Thanks, Hannah. That's really valuable. Did you want to ask a question, or I'm happy to go for another one?
I will ask. So should an ECG be routinely offered to all patients with severe mental illness annually, or when conditions are mentioned on the updated list at all?
Shall I? Karen, you need to. Well, it's 20 years since I was a proper GP, so I may not be talking good sense. My understanding of when an ECG is important, there are obviously, it's a complex issue. So the mortality guideline have got a very well written but very complex set of guidance. The issue is about developing dangerous arrhythmias. So and the risk of sudden death. I mean, so we're talking a very, very serious issue. An initial ECG is helpful, particularly if you're taking a certain types of antipsychotics. It's not universal for all antipsychotics, but most antipsychotics will have some impact on your electrical conduction of your heart. That's right, is it, Carolyn? I mean, not.
It is, yeah.
Yeah. But some more than others. So there's a sense that for certain antipsychotics, then certainly a baseline ECG is important, and then potentially to follow that through with further ECGs. And there I'm getting out of my depth now. Karen, go on.
Well, yes, and then you know, I would have to look at the mortality guidance, which is not easy. And I think the other thing to say is it's not in QOF, and it would be a tremendous workload. And every piece of work that's done in general practice has to be funded. And so it's up to commissioners to say this is important. If ECGs are needed, and the problem is that resting ECGs can be not very helpful, because you can have a normal resting ECG and still have sudden death, unfortunately. But if the evidence was that a resting ECG was important for people on antipsychotics, then that has to be commissioned and it has to be paid for.
But it's a prescriber's responsibility. And the other point I'm aware of is that if you're in an inpatient service, then that's a much more stressful situation. That's another factor in increasing the likelihood of having a cardiac arrhythmia. Yeah. So I think I'm sure that NICE actually mandate that if you're in an inpatient service, you should be offered an ECG because of the risk and taking antipsychotics.
Yeah. And it should be done in the inpatient, so it shouldn't be a letter to the GP to say this person needs an ECG. No, so again, it's about collaboration and liaison across that interface.
And then I think there are clear guidance on the actual, it's the length of time between your complex QRS when your heart fires and the recovery phase, the T wave. It's the gap between the QRS and the T, and if that lengthens beyond a certain amount, it is dangerous. So there's absolutely no doubt that the ECGs are important for some people in certain situations. But as I say, it's a complex. This is complex. We need I'm sure there'll be experts.
We need a guideline on this on its own, because there's some antidepressants that you know, people need an ECG if they're on high dose antidepressants. Sorry.
Can I just ask, sorry, so I'm just looking at the Leicester tool, the previous one, so it does actually give some advice on there about ECG. So is that still on the 2023 updated?
Yeah.
Okay, fine. Okay, thank you.
Yeah. And I think we lifted that from NICE basically. And why wouldn't we?
For sure.
Yeah. I noticed Dolly's. This is an expert we really do need on this question.
Thank you, David. Thank you. So I'll put a few things in the chat about ECGs. The other issue that we have, which we need to address from a secondary care point of view, we've got a lot of things that we need to do in secondary care, is that the ECG training that is available to our clinicians isn't fantastic. So from a personal level, what I've done is I've organised ECG training with our cardiologists to come across from the acute trust and do some face-to-face training with our psych trainees, our consultants, who some of our consultants haven't looked at an ECG for a significant period of time. Yeah. And whilst there is some online training, as far as I'm aware, from the Royal College, that face-to-face interaction is critically important. So we've written a syllabus. We're very lucky in Leicester. We've got GPs that work in on our adult unit and our mental health services for older persons and learning disabilities as well. And I've worked with them to get this training in place. It hasn't been straightforward, but it's absolutely needed. And we've been oversubscribed, so we're hopefully going to go for a second cohort. But interestingly enough, this isn't mandated by the trust. And I'm trying to get that in place. So this is something that we've just done from knowing that people are telling us. We've done a pre-learning survey, we've done a post survey, we may publish the results, but there's a gap in the training for our clinicians in this area as well. And let's not even get started on reading ECGs from CAMS, because we have to go to paediatric services, very specialist. So there's a lot that we need in secondary care. it's yeah, we still need to push things forward. Yeah.
Good question.
You can get ECG machines that link in, for example, with Broomwell, and they interpret them, and that's what we use in general practice. So really, clinicians shouldn't have to be thinking, I've got the responsibility for interpreting this ECG, but often mental health trusts don't have the whiz-bang ECGs that we have in primary care.
Okay,
Hannah, we've had a couple of people with their hands up, so can we just take questions from them? So I think Nicola and Emma, if you still have your questions. Nicola, do you want to go first?
Yeah, thank you. Hannah, I wanted to ask you, can you hear me okay?
Yeah.
Yeah, it sounds like you've now got the services that you wished you'd had, but have had to go to hell and back in that journey, because you said, you wish, someone asked you, didn't they, what do you wish had gone differently? What would have helped? Which I'd put that in the chat. Do you feel through primary care and secondary care, if you were accepting of antipsychotics and a medical route, that you would have been like to be informed from the off what that impact, what the impact might be on the other aspects of your health, like holistically, so that you would be aware that it wasn't you just overeating, it wasn't you over smoking, and the impact of that. Because when we have physical health, when we invite people for physical health checks, they're often averse to people asking about smoke, do you smoke? But they actually don't know why they're asking. That's my experience. So do you think if that was changed, and like Carolyn says, we had a joint approach from primary and secondary, you'd have make more informed choices at that stage?
I think if I was more aware of it, and I think if I would have been told about the side effects of the medication that I was being put on, I would have said, look, I'm a ballet dancer. I don't want to put on like 4 stone in 4 months and then never be able to dance again. Like it completely changed that for me. And I think if someone had warned me about the side effects or had tried different drugs, because sometimes I think I didn't actually need all of those drugs either when I was so young. And then when I went into secure services, that's when I put on most of my weight, like as an adult, and there was nothing to do. We would have breakfast, lunch, dinner, and then supper, which is 4 meals a day. And there'd be, if you weren't allowed ground leave, they would do a shop run for you. So you write down what you wanted from the shop, the hospital shop, and I would have already eaten 5 pieces of toast, 4 eggs, and a bowl of cereal in the morning for breakfast, and then go and got 4 chocolate bars and 4 packets of crisps that I would then munch at 11 o'clock, and then go and have my lunch. And now there are more provisions for people in secure care and in inpatient services, because I had a recent admission because I had a change of medication, which has helped me lose the weight, which has really helped me lose the weight, because I asked to come off of medication, but unfortunately I got quite ill while I came off a depot because I didn't start the medication properly. And anyway, it's a long story. But if there had been like early intervention in my physical health needs, then it would be a different story. And like, it was, my family are only just starting to realize now that I've changed the medication that actually it was the medication that made me put on weight. It wasn't me just being greedy. And that has been a real, like, my dad is I love my dad to pieces, and he's amazing in every single way, but he is very focused on weight, and so is my mum. They're separated, and I've always been the fat one in the family. Everyone else is tiny, and like my sister had anorexia, and I've always been the fat one. And they are finally realizing, actually, now that I've been taken off all the medication like olanzapine and quetiapine and everything like that, and put on aripiprazole that keeps me awake, not to sleep. So I'm awake all the time now. I struggle sleeping, but they're finally starting to realize that actually it was the sugar cravings. So yeah, and that's been real quite emotional for me, because they're realizing now, and medical professionals are as well, and hopefully maybe changing other people's medications to other things. I hope I answered your question. Sorry.
Yeah, no, you absolutely did. Thank you. Thank you.
Thank you. Emma, you have your hand up. I think you were next.
Thanks, Hannah. It was coming back to the ECG, and I don't want to labour the point. Lots of people have had discussions. I'm a GP, and I'm leading the work on physical health monitoring and mental health in Devon. And trying to tackle it as a system, a collaborative approach. So, primary care, secondary care, voluntary sector, and I've put in the chat about, trying to make sure that everyone who needs a check, that we've reaching out to them. So if they're not responding to primary care, a secondary care got them on their caseload. If not, can the voluntary sector do some outreach to try and contact patients, make them understand about the physical check and why it's important. I think that's a lot of what we're missing as well, and having some really good solid comms that we can put out to people when we're inviting them in. I think in primary care we do it very differently, practice to practice, don't we? And that if you had some consistent validated information that was co-produced, I mean, the Rethink leaflet looks great to me, and they've redone it and it's colourful, and I'm going to start sending that out as a PDF to our patients and encourage my PCN colleagues to do the same. We're trying to create like a comms, one Devon comms that we can send out, some little video clips about that demystify and myth bust and make people feel more comfortable, to let them know that we can make reasonable adjustments for them to come in. But also on the ECG, it is an INQOF, but actually people on antipsychotics, and it's not just people on the SMI register that this affects. And what's disappointing for me, and I wonder, Layla, if NHSE can look at this, is about extending this to people who have, it's not just people who've got a psychotic diagnosis, psychosis diagnosis. It's anyone on antipsychotics have an increased cardiometabolic risk, and we're not capturing those. So we're actually driving more health inequality in our mental health cohorts. So that's wrong. So as a system, what we're trying to look at is, how do we commission pathways that can for us, Carolyn, like you were saying, we're not in primary care commissioned to do that unless your system commissions you to do that. So we're looking at possibly a new local enhanced service around physical health monitoring in mental health, to include the physical health check extra stuff, that interventional stuff, not the physical checks, to include ECGs for people on antipsychotics and the cardiometabolic risk out. So doing the Leicester tool in those 6 checks, plus also looking at an extended service for if primary care feel that they can take some of the monitoring for eating disorders. We're a very massive geography with lots of rural areas that patients struggle to get into the main centres for those checks for eating disorders too, for many reasons, transport, cost, whatever. So it's about having a local offer, but not expecting GPs to analyse all of it. And the ECGs, the model we're looking at for the antipsychotic monitoring, because the key thing was more around the QTC. So we can use a 6-lead ECG for that. It doesn't mean patients getting undressed, it's a shorter appointment. But I think in primary care for us, I think you might agree, Carolyn, we are used to doing the 12 leads, we get more information. But where patients are getting picked up with hypertension, that should be getting back to general practice to do a 12 lead when needed. So I don't think mental health trusts have to get overly concerned about having to do 12 leads and analysing them. Do what's important for the bit of work you're involved in. Pick up the risk. If there's a risk, you pass it back to primary care. That's where all of that stuff should happen. And if we can't interpret it and we're unsure and it's not bundle, we will refer on to cardiology. So I think we get a bit messed up and we try to do too much that we shouldn't be doing. So let's get the right people doing the right things and work collaboratively together. That's what I think we need to focus on. And Layla, about the antipsychotics, if that can be brought into QOF, brilliant.
I'll just very quickly say on that point, largely thanks to many other stakeholders, including Peter Pratt, in the new guidance is very much focused on the physical health monitoring of those on antipsychotics, mood stabilizers and sodium valproate. regardless of diagnosis, because we know this is a growing issue. And I'm very much focusing on this, what we can do more in this area. Getting things into QoF at the moment is going against the grain of the political direction, but looking how else we can try and push that focus, I think, is really important. So thank you for raising it.
Can I just say something on that? Like a lot of people in personality disorder units are being put on clozapine, and I think it's just to mong them out so they don't do the behaviours that they're used to doing, and that's not the way to do it. It's like what David said about feeding forgotten, and I've forgotten, sorry David, what you're
fattened, flattened and forgotten.
Yes, exactly. And I see it over social media of my friends in PD units who, another girl who obviously I won't mention her name, she was a dancer when I knew her in an acute ward. She's now in a PD unit and she's ballooned, and she's not going to ever go back to, she was so passionate about it. So yeah, we've only got a few minutes left, so I'm gonna, who should I go to? Should I go back to, I know Gareth, you've had your hand up for a while. Would you like to just come in and say something?
Yeah,
so David,
can you hear me okay?
Yeah.
Yeah, so I put a question into the chat and I'd just like to elaborate a bit on that. So you're all going to be aware that people with SMI will have motivation issues, functional deficits, so it's going to be very, very difficult for them to implement or to maintain any sort of behavior change. Like, so in my opinion, as a dietitian in secure services, I'm very much of the opinion that psychological support is really needed in things like dealing with cravings, finding alternative coping strategies instead of snacking, impulse control, dealing with the shame of weight gain. So I'd just like to get your opinions on how best we can use psychological support or therapies to help improve physical health outcomes.
I agree with you, Gareth. I agree. I did a wee reply there. Yes, I think that would be very valuable, or is very valuable for many parts of the intervention. And sometimes perhaps like dietitians, but perhaps psychologists, for example, or possibly in some areas are more scarce than dietitians. I'm not sure how it is in Oxford, but that in terms of recruitment, I don't want to.
Yeah, I think there are psychologists based on most wards in our unit, so we're very much outnumbered by the psychologists, but at the same time they're very much focused on the psychosis side of things, of the psychologists, these more mental health side of things, rather than in an attempt to deal with their physical health issues or to deal with mental health issues as a result of their physical health issues, if that makes sense. I think there's a lot of work that can be done. There is a big gap in what we're offering, and a lot of services are offering. So I just want to get anyone's thoughts to see if you've ever thought about this stuff.
In our weight management service, in other words, tier 3, which isn't in mental health, where I have worked previously, we used to do joint sessions with the clinical, or it was a clinical psychologist, the dietitian and psychologist. We worked together. Our patient group wasn't necessarily people with severe mental illness, although there were 1 or 2 people in it, but we did work together in a different setting. So I think even more so, perhaps it would be helpful in the mental health setting.
Absolutely.
Thank you. I'm going to go to David now because
thank you.
Yeah. I just make a final point really about expectation. I think one of the things that we've had to struggle with is having a low expectation as a carer. And if you don't expect a lot, then you know that's a really important part of this. I won't digress too much, but we had oral health is an interesting issue. Mary's present care home take immaculate care of her oral health. Previously, it had never been taken any notice of at all. And actually, because our expectation was so low in the previous homes, we just got to sort of complaining about the state of the toothbrush, but nothing was done. Present home, it's brilliant. So I think the expectation is very important, and that's something I think as professionals you can help with. You have to recognise that people are in a very difficult space, and actually they need a lot of support. And the other point I'd make is about personalisation. That I think what you're describing, Hannah, and what Mary experienced, it was almost like they didn't know who they were, didn't know that actually you're a keen dancer. And actually, that's a huge opportunity from a psychological perspective. Like, who are you? What is it that makes you tick? So I think the opportunity to actually personalise care, to know who someone is, to know them well. Families, of course, know people very well, in terms of their own families. So we are an untapped resource in that sense. But I'd just like to emphasise this importance of low expectation. And part of the challenge of the Leicester, I think, is to try to raise expectations that people should expect more from services. Thanks.
Thank you, David. I think we're going to have to come to the end of our session, but just thank you so much, David, and Catherine and Carolyn, for being part of the Leicester Talk, like this webinar about the Leicester Toolkit. I think it's been helpful for me. It's been really interesting for me. Thank you for everyone attending. Thank you for Shazana, who's in the background doing bits and stopping me when I should stop talking. I don't know. Not sure what to say now, but thank you. Yeah, so I'm going to just give back
Brilliant.
to Shazana, and so well done, everyone. Thank you.
Yeah, just to reiterate, thank you to everybody, and we will be sharing the recording. And David, if it's okay if I can share the slides afterwards, people have been asking.
That's fine. Yeah,
that would be great. And there's so much stuff in the chat as well. It's been brilliant, kind of just reading all your discussions. So thank you, and I'll share as much of that as possible. But yeah, thanks again.
Right. Okay. Very good.
Thank you.
Thank you.
Bye-bye.
Bye everyone.
Thank you. Bye.